So do you think that a non-oral on-demand therapy, whether it's subcutaneous, mucosal, inhaled, should be given to patients when the oral levodopa takes longer than 20 minutes or longer than 30 minutes? Or how can general practitioners think about when do I give an on-demand non-oral therapy to my patient?
So I look at it as 30 minutes, and don't ask me how I came up with the 30 minutes, because some of it is based on, we have patients who say, oh, I take a pill, it works within 15, 20 minutes. So to me, 30 minutes is a pretty good time. Looking at your study, where patients in the morning were on an average 45 minutes, isn't that correct, that they were taking for their morning medication to work? To me, 30 minutes seems like a reasonable time period on it.
You could also frame it in, what are the consequences if you have an episode where you don't get on? You're driving your car, you're at work, and embarrassment or something having to do with the perception of your capabilities. Having no episodes of off because you have a way to deal with that is another axis of thinking on this.
Right, I think each patient, right, it truly is, it's the old saw. If you've seen one case of Parkinson's disease, you've seen one case, right? Every patient is different. If I had a patient who was taking levodopa 3 times a day and was generally doing well, but was occasionally having an unpredictable off, I think that would be a patient who would be ideal to try inhaled levodopa for, right? So, because you don't have to increase the burden of having to take their levodopa 4 times a day, you can give them an on-demand therapy that is relatively socially acceptable. People find inhalers, using them in public is not a big deal for them. And, I think if I had a patient who was having, in general, doing well with levodopa 3 times a day, but was having difficulty getting to work in the morning because they woke up in a real off state, I think that would be an ideal patient to think about subcutaneous apomorphine. We have the data from the AM Impact study that showed that can be a very effective therapy for those people to allow them to get on with their day and work. So I really think you have to look at that patient, how, as Peter said, it's impacting that person's life, what the consequences are, and tailor the therapy to them.
It may not just be how long it takes, but is it once a day,
right,
once a week, once a month, only a special occasion like a wedding or going to Disney World with the grandchildren? So,
Or on the other side, 5 times a day.
or 5 times. But how do you decide the patient has an off episode once a month? Would you give them an on-demand non-oral therapy?
If the consequence is, let's say they're not leaving their home because of that fear of it really happening once a month, but the perception it might happen anytime. I mean, I can imagine that at least putting that information in front of the patient, that you don't have to stay holed up, you don't have to retire early, there isn't really a safety issue in your life if you have this EpiPen for Parkinsonism. That's the way to couch it. I think the average person who gets it prescribed uses it regularly, and those who don't use it once a month at least obviously drop off from therapy. They may have tried it, but at least gives them confidence for their future, where if they go to a support group meeting and hear of all the people who are fluctuating and having hours of off time, they know that that isn't in their future if they take advantage of these therapies, and especially with apomorphine as a therapy that overrides off time that can occur even with continuous infusion. Some patients who are on Duopa infusion are using apomorphine because levodopa can shut down on them for who knows why.